since a few years we're trying to send her for the operation. Have power and directly with this lady, and that's why we decided that the bridge to surgery will do now we showed to you what the power artery was looking. We have a number of reps and downs. Now you see the left artery. The left artery, the left artery, you have some pouches, subtotal occlusions, and unfortunately, the lower lobe arteries was not very good. So we did in a row, and we dilated 4 times the right and 1 time the left. And that's against our odds. Actually, we do 1 by 1, left, right. But in this situation, we have complications. And when we try to recanalize the left the branch of the 8-segment artery, we will have extravasation. So we abandon it, where we put some sponge and we leave. So that's it for today. We have hemodynamics already. We have pulmonary artery pressure of. We started with something like 52.
How much was pulmonary pressure? Because there was
and maybe we'll show you what we did now.
Yes.
To the session today. Okay, let's start here. Okay, what we see, it's a regular, I guess it's a 9-segment artery, and you see 8 segments which will dilate. And then we more closely engage this very large branch, which is supplying the base, the left lower lobe. It was well dilated 3 months ago, but we have a residual stenosis of membrane in the middle. So that's why we first nothing besides, and we did a small balloon dilation of the periphery. Then we went up, and then we changed for the balloon diameter of 4.
What was size the balloon of this balloon? Vasco, what was the size of the balloon?
4 by 20. Okay. So that's 4 by 20 balloon.
At what pressure?
For the waist of the 4 by 20, and we can see. And now we are moving brain, and we are going to repeat the dilatation of the periphery with a small balloon, and then we'll see what happens. Our philosophy is that we want to spend as less and our lady has problem with a very severe tricuspid regurgitation in the kidney failure. We'll now check what we did with the last balloon.
Professor Velchev, could I ask you what
Sure.
kind of balloon do you use? Semi-compliant or non-compliant? NC?
Usually these lesions are not that tight. I will have a presentation later. With us online.
In fact, the connection is not very good.
Okay, I understand. Relievement of the stenosis, and you have now, I just will show you, and okay, it's Sorry for this. Okay. Which is the branch, and you see the membrane. And now you can appreciate on our final result that we have better flow and bigger caliber for this branch, and this stenosis doesn't look very tight now. We never size 1-to-1. So we measured this vessel, it's a caliber of 6 millimeters. So we are on the and we rely on the remodeling of the vessel. Results for now, and we'll try to go in the upper lows because our lady have a kind of little bit hypoxic. Can you please try to select the upper vessel? We have a rule, if you want to put down the pressure, you go for the lower lobes. If you want to improve the oxygenation mainly, you go for the upper lobes. In this situation, we want both. So we are going with...
This is a good call.
We have a complication last time, we leave it alone. And now we're going through the 1, 2, 3, and 4 segments. And we'll try to see whether we have visible membranes and try to delay them.
The wire you use is coronary wire, or?
It's a coronary wire. It's no, it's Terumo wire. We're using a Terumo regular wire workhorse.
Okay. And now the plan is to go on the upper lobes, yes?
Yeah, we're going for the upper lobe.
Okay.
In order to selectively go to another branch, do you use 0.35 wire or you?
No.
No.
0.35, in this situation like here, we're working from the jugular, we have a big curve in the right to rotate the catheter. And sometimes we have a problem, but we try gentle strategy, we're not using zero. It all rotate. So just a few words about the philosophy of this procedure. What we learn from the that we have to do it very, very predictively, and in order to be safe, you go with a small balloon, you predilate, you want Now we're trying to engage. Always easy, and our destination is helping. Okay. We want to see what we selected. Good. To be completely safe, I will push my wire a little bit up, just to be sure that I'm not. Първи леко въздух. Не дишай за момент, не дишай. Дишай спокойно. We don't have lesions, at least in my view, at this segmental artery. So I guess we are not doing a dilation here. We'll try now to go for the first segment.
And the guiding catheter you use is the right Judkins catheter, yes? This Judkins right?
Catheters, but in this specific situation we have very high branching of the lower lobe arteries. And that's why we switched to okay. So at least on the left, it looks like we don't have here.
You
So
use
I
only
guess
only one oblique projection, or you made angiography in two perpendicular? What is the, because as far as I see you're on the left.
Biplane, and we have a rule, we never go beyond 100 cc of just 50%, so we have for the procedure 20, and now we already have 100 injected, we have 100 more, and that's why usually, if we have good diagnosis, we don't do both sides. But you have here, so that's another sign that we have nothing to gain here. Okay.
And Vasco, do you use as a planning tool a CTA, pulmonary CTA, or you rely only on selective angio in order to decide what to treat?
Because I'm a very, very, very good quality, and now we will maybe follow your advice and to go back and check for the middle lobe segments. We'll put our guiding down. We don't want any additional, and we're trying to be as gentle as possible.
So the plan now is to go back to the lower lobes,
yes,
and
to the middle lobe,
to check for residual stenosis in another branches, yes?
Absolutely. We're now going back to the lower lobe. We'll check for the additional stenosis of the lower branches, but we will try to avoid complete occlusions, okay?
Okay. So occlusions are not good for live demonstration.
But in this situation, we may have a problem because we already tried one, and you need a stiffer wire for occlusions. A stiff wire means more here, the first place, so we're not coming back here.
And,
okay, we overturned the catheter, so we'll change the guiding now.
And another question is, did you make a monitoring of the systemic blood pressure during this procedure?
Usually we just put non-invasive blood pressure, and most important, two warning signs: saturation, fall, and cough. Is not falling, and patient not coughing, we feeling very, very.
So the monitoring of saturation and coughing, yes?
Yes, and what we have in the protocol, the patient don't stop the medication, so she is on the liquids and she stays on the liquid during the procedure. Sorry. And then we have additionally enough. So we don't put more than 3,000 cc of heparin. But we don't stop the liquids. That's another reason we don't like to have, don't like Рем въздух. Диши спокойно.
Vasco, and what is the anticoagulation, antithrombotic regimen around the procedure and post-procedural? Do you give some antiplatelet medicines, or you rely entirely on anticoagulation?
old anticoagulation-like syndrome, we are feeling very secure with syndrome. And if the patient is not feeling comfortable on the syndrome, so we're using DOACs.
Yes,
Now
I
it
understand.
looks like
But
we are going.
did you use antiplatelet agents also
No, no,
in
neither
combination?
before, neither after.
Okay, so you rely only on the syndrome, on acenocomarol, and
We rely on the NOACs.
do you make some switch around the procedure to heparin?
No.
Just
We put additional heparin, like 3,000 units, but
okay.
we don't switch, so we're not heparinizing fully.
You don't monitor with ACT or APTT, something like that?
No,
No, okay.
we don't do it. Works. So actually we have here a tiny branch. Dinko, can you show to the camera our tree? Easy to recognize. So we now
Okay. This is for this patient, yes, okay.
no, that's not for this patient. It's just kind of we're using it to remind us which segment it were.
Aha, okay.
And were part of this target stenosis restenosis or not?
No. So, още малко напред. Още малко напред. Само опали водача. Така. Окей, стига. Да. Ирен, появи въздух и задръж. Малко напред балона. Дишай спокойно. Дай назад.
What is the size of this balloon? This is 2.0 to 20?
Small balloon. Появи и не дишай. 220.
220. And the pressure is up to complete opening of the balloon, yes?
Yeah. And now we'll check the result. Okay.
Quite good. So you...
Need to go to the smaller branch. I guess that's enough. We'll try now just to flow 4. Just open if you have a proximal membrane, but we don't see any proximal membrane here. So I don't think we need to. Usually we try to limit our dilation to 3 segments per. I guess that we are ready to finish now, and we'll check now. Can you see our pulmonary pressure?
No. Maybe you have to switch transmission to the... can you turn to the left the screen with the pressure recordings?
Sure.
Just to be in the direction down, please. Just to see the pressure curves. Yes, it is 62 systolic pressure. 59, 62. What was the initial pressure of this patient?
Initial kind of a 47, but it's a little bit tricky. If you want to compare the hemodynamics, she needs to go 2 weeks from now and just to measure hemodynamics, because we have some problems with measuring the output in acute setting. And then again, I have some nephrotoxic and capillary toxic effect of the contrast. So sometimes when you see this, is just because we have a little bit fall of the cardiac output. Ники, заангажираме и ти, ако обичаш да пресъдиш отдясно през сърди. Това са цялата система. And now we are moving to the right atrium, and I will show the pressure in the right atrium. So that's the situation. Да, дърпаш.
We see you have upper approach. Are you using a cubital vein or a subclavian vein?
Dobrin, I didn't hear you. We have a question.
Ivo asked, yes.
Vasco, we saw you have an upper approach. I'm asking you, are you using cubital vein or subclavian vein? What is your vascular access?
No. Not good for this situation. Then we have can give you a spasm if you have prolonged procedure.
Could you repeat?
So
we didn't hear.
Usually we do it from the femoral most of the time. But the patient comfort is better if you do it from the head because they don't have to lay prone and so on. So sometimes we do it from the jugular. But me personally, I prefer to do it from the femoral vein. It's my personal preference. In Bulgaria, we have a problem that if then you can't maneuver or guiding quite good because if you put too long a guiding, then you have a problem because you need a balloon with a very long shaft. Destination and the regular length of guiding.
Okay,
so you now see, може и пак. I have to remind you that 2 years ago we started with right RV pressure of 24, and now we have mean RV pressure of 12. But unfortunately, you can appreciate this very huge V wave because about this tricuspid regurgitation, and the TAPS of the patient is 13. So unfortunately, I guess we cannot fully resolve the obstruction, and to present the case to Professor Klepetko in Wien, and then to have a shared decision what to do next, to prepare for the high-risk surgery or to continue with the BPA, but we need also the opinion of the surgeon, and then we'll decide what to do next.
Okay. So, some other questions? Okay, so we finish with the case. That was a very good demonstration of the BPA technique. I would like to thank the whole team from St. Anna and Professor Velchev, Dr. Stoyanov, Dr. Kamburov.
Billy, which is behind my back hiding, and Milena.
Yes, okay, so thank you guys.
Thank you.